The early arrival, patient 1 of 6. Over the next 5 nights you will follow one client from the first queue to the final evaluation, and work every question with the full rationale. Here is what happens. Night 1, preterm labor and PPROM. Night 2, chorioamnionitis. Night 3, chorioamnionitis and delivery. Night 4, neonatal resuscitation. Night 5, surfactant response. Let's begin. Night 1 of 5, preterm labor and PPROM. The clinical judgment step tonight is recognize cues. 30 weeks, a trickle of fluid, and a clock that just started on 2 lives. A 27-year-old at 30 weeks 2 days reports contractions every 6 minutes, low back pressure, and a gush of clear fluid followed by continued leaking. Nitrazine paper turns blue and ferning is positive. The cervix is 2 cm, 50% effaced. Fetal heart rate baseline is 145 and reassuring. Temperature is 37.0 C. Which action should the nurse take first? Option A. Perform hourly digital cervical examinations to track labor progress. Option B. Avoid further digital examinations and begin continuous fetal monitoring. Option C. Encourage ambulation in the hallway to promote labor progress. Option D. Insert an indwelling urinary catheter to reduce bladder pressure. Take a moment. The answer is B. Avoid further digital examinations and begin continuous fetal monitoring. Nitrazine blue plus positive ferning confirms ruptured membranes. Every digital examination sweeps vaginal flora upward toward the uterus and measurably raises the risk of chorioamnionitis, so exams are minimized and a sterile speculum is used if visualization is needed. Continuous fetal monitoring is essential because the loss of amniotic cushioning makes cord compression and cord prolapse a live threat. Hourly digital exams are precisely what drives the infection risk. Ambulation promotes the labor you are trying to stop at 30 weeks and increases cord prolapse risk with a high presenting part. A catheter adds another portal for bacteria and does not address either priority. The trap? Managing this like term labor and checking progress. At 30 weeks with ruptured membranes, the goal is to stop labor and keep bacteria out, not to track dilation. Pearl of the night. PPROM. Nitrazine blue, ferning positive. Minimize digital exams, monitor continuously, and watch for cord prolapse and fever. Night 2 of 5, chorioamnionitis. The clinical judgment step tonight is analyze cues. Previously, last night, 30 weeks, ruptured membranes, and we kept our hands off the cervix. 18 hours later, the fluid has a smell, and the baby's heart rate answers first. The same client is now 18 hours from admission, receiving magnesium for fetal neuroprotection and a second dose of betamethasone. The nurse compares the admission assessment with the current one, comparing on admission to now 18 hours. Maternal temperature, 37.0 C to 38.9 C. Maternal heart rate, 88 bpm to 122 bpm. Fetal heart rate baseline, 145 bpm to 178 bpm. Amniotic fluid, clear, odorless to cloudy, foul-smelling. White blood cell count, 11,200 to 22,600. Based on the trend, which action is the priority? Option A. Notify the provider, obtain cultures, and anticipate Roman IV antibiotics with expedited delivery. Option B. Continue to cholecyst to prolong the pregnancy toward 34 weeks. Option C. Administer an antipyretic and recheck the temperature in 2 hours. Option D. Reassure the client that maternal fever is an expected effect of betamethasone. Take a moment. The answer is A. Notify the provider, obtain cultures, and anticipate Roman IV antibiotics with expedited delivery. Maternal fever with both maternal and fetal tachycardia, purulent foul-smelling fluid, and a climbing white count is chorioamnionitis. It is an intrauterine infection, and the only definitive treatment is emptying the uterus. Broad-spectrum Roman IV antibiotics plus expedited delivery protect both patients. Tucolysis is contraindicated once intraamniotic infection is present, because prolonging the pregnancy now prolongs fetal sepsis exposure. An antipyretic masks the single most important cue. Betamethasone does not cause maternal fever, so that reassurance is both false and dangerous. The trap? Treating the fever as a nuisance instead of a diagnosis. Fetal tachycardia often rises before the maternal fever does. Pearl of the night, chorioamnionitis. Maternal fever, maternal and fetal tachycardia. Uterine tenderness, foul fluid. Antibiotics plus delivery. Tucolysis stops. Night 3 of 5, chorioamnionitis and delivery. The clinical judgment step tonight is generate solutions. Previously, last night, the fever, the foul fluid, and a fetal heart rate of 178. Bow tie night. The fever has a name, and it means the baby is coming now. Chorioamnionitis is diagnosed at 30 weeks 3 days. The client is febrile at 38.9 C with a fetal baseline of 178. The team is preparing for delivery. Complete the bow tie. 1 condition, 2 actions, 2 parameters. Pick the condition. A. Chorioamnionitis. B. Placental abruption. C. Acute pyelonephritis. Pick 2 actions. D. Administer broad-spectrum Roman 4 antibiotics. E. Expedite delivery and notify the neonatal resuscitation team. F. Continue to colysis to reach 34 weeks gestation. G. Discharge home on oral antibiotics with clinic follow-up. And 2 parameters to monitor. H. Maternal temperature and white blood cell count. I. Continuous fetal heart rate pattern. J. Serum amylase and lipase. K. Maternal fasting blood glucose. Take a moment. The condition. Chorioamnionitis. The actions. Administer broad-spectrum Roman 4 antibiotics, and expedite delivery and notify the neonatal resuscitation team. Monitor. Maternal temperature and white blood cell count, and continuous fetal heart rate pattern. Chorioamnionitis is an ascending intrauterine infection. Broad-spectrum Roman 4 antibiotics treat the mother and reduce neonatal sepsis, and expedited delivery removes the infected environment. Because the infant is premature and infection-exposed, the neonatal team must be at the bedside before delivery. Abruption presents with painful bleeding and a rigid uterus, not purulent fluid. Pyelonephritis produces flank pain and costovertebral tenderness without foul amniotic fluid. Tocolysis and discharge both leave the fetus inside an infected uterus. The trap? Choosing to keep the baby inside for lung maturity. Every additional hour in an infected uterus is another hour of fetal sepsis exposure. Pearl of the night. Chorioamnionitis bow tie. Recognize the fever and the fetal tachycardia. Give antibiotics, deliver, and have NICU at the bedside. Night 4 of 5. Neonatal resuscitation. The clinical judgment step tonight is take action. Previously, last night, antibiotics, delivery, and the NICU team called to the bedside. He weighs 1,420 grams, and he is not breathing. You have 60 seconds. The infant is delivered at 0412 at 30 weeks 3 days weighing 1,420 grams. He is apneic with poor tone and a heart rate of 88. The neonatal team receives him at the radiant warmer. Place the neonatal resuscitation actions in the correct order. Option A. Place under the radiant warmer and cover in polyethylene wrap without drying the body. Option B. Position the head in a neutral sniffing position and clear the airway if needed. Option C. Begin positive pressure ventilation for apnea with a heart rate below 100. Option D. Attach the pulse oximeter probe to the right hand for productal reading. Option E. Titrate the oxygen concentration to the minute-specific target saturation range. Put them in the correct order. Take a moment. The correct order is: first, place under the radiant warmer and cover in polyethylene wrap without drying the body. Second, position the head in a neutral sniffing position and clear the airway if needed. Third, begin positive pressure ventilation for apnea with a heart rate below 100. Fourth, attach the pulse oximeter probe to the right hand for productal reading. Fifth, titrate the oxygen concentration to the minute-specific target saturation range. For infants under 32 weeks, thermal care comes first and the body goes into polyethylene wrap without drying, because evaporative heat loss from a 1,420-gram infant is rapid and lethal. Airway positioning follows, then positive pressure ventilation within the golden minute for apnea with a heart rate under 100. The oximeter goes on the right hand for a productal value, and only then is oxygen titrated to the minute-by-minute target range. Ventilating before positioning wastes breaths on an obstructed airway. Placing the probe before ventilation delays the single intervention that raises the heart rate. Titrating oxygen before reading is guessing. The trap? Drawing a 1,420-gram preterm infant like a term baby. Under 32 weeks the body goes into the wrap wet, because evaporation is what steals the heat. Pearl of the night. Preterm NRP. Wrap without drying under 32 weeks. Ventilate within the golden minute. Productal saturation on the right hand, then titrate. Night 5 of 5. Surfactant response. The clinical judgment step tonight is evaluate outcomes. Previously, last night, the golden minute, the wrap, and surfactant down the tube. 12 hours after surfactant, the numbers tell you whether his lungs listened. 12 hours after surfactant administration and transition to nasal CPAP, the neonatal nurse reassesses the 1,420-gram infant. Which findings indicate an appropriate response to surfactant and CPAP? Select all that apply. A. Oxygen requirement decreased from 60% to 30%. B. Decreased intercostal and subcostal retractions. C. Breath sounds equal bilaterally with symmetric chest rise. D. Sudden decrease breath sounds on the left with a shift in the point of maximal impulse. E. Blood gas improved from pH 7.21 with PaCO2 62 to pH 7.34 with PaCO2 44. F. Rising oxygen requirement with new grunting and nasal flaring. Select all that apply. Take a moment. The correct answers are A, B, C, and D. Surfactant lowers alveolar surface tension, so a working response looks like a falling oxygen requirement, less work of breathing, symmetric aeration, and a correcting respiratory acidosis. Those four findings together say the alveoli are staying open. A sudden unilateral loss of breath sounds with a shifted point of maximal impulse is a pneumothorax, which is a known complication once lungs become more compliant after surfactant. A rising oxygen requirement with new grunting and flaring is deterioration, not response. The trap? Explaining away a sudden asymmetric change as a displaced probe or repositioning. After surfactant, asymmetry is a pneumothorax until proven otherwise. Pearl of the night. Surfactant works when oxygen need falls, retractions ease, and the gas corrects. Sudden asymmetry equals pneumothorax. Transilluminate and call. That is all 5 nights with this patient. The 5 pearls. One more time. PPROM. Nitrazine blue, ferning positive. Minimize digital exams, monitor continuously, and watch for cord prolapse and fever. Chorioamnionitis. Maternal fever, maternal and fetal tachycardia, uterine tenderness, foul fluid. Antibiotics plus delivery. Tocolysis stops. Chorioamnionitis bow tie. Recognize the fever and the fetal tachycardia. Give antibiotics, deliver, and have NICU at the bedside. Preterm NRP. Wrap without drying under 32 weeks. Ventilate within the golden minute. Preductal saturation on the right hand, then titrate. Surfactant works when oxygen need falls, retractions ease, and the gas corrects. Sudden asymmetry equals pneumothorax. Transilluminate and call. That is the full case. Over 1,000 free study guides at www.clinicaljudgern.com. No paywall, no catch. Like, comment, share, and subscribe for the daily questions. Educational content only, not medical advice.